Hello and welcome everyone. Today we'll be discussing about covert consciousness in critical care. So what is this? Covert consciousness refers to patients who appear unresponsive, that is, they are comatose, but they still have a conscious brain activity, which can be detected by advanced methods like EEG or functional MRI. Think of it like someone who is locked in, who is awake inside, but is unable to show us in our physical examination that he is conscious and responding to our commands. So why is it relevant in the ICU? Around 25% of the unresponsive ICU patients might be having this covert consciousness. These patients have better chances of long-term recovery, but they are often missed because our standard assessments of GCS and motor activity is unable to detect any response, and they're termed as comatose. Early detection can guide more accurate prognosis, avoid premature withdrawal of care, and enable targeted rehabilitation. So what are the key terms? The most important is the DOC or disorders of consciousness. These are states like coma, vegetative state, where the consciousness is reduced or affected. Cognitive motor dissociation. The brain is active and follows commands internally, but outside the patient is unable to generate any motor response to show that the patient is responding to any of our commands. Functional MRI, this imaging that detects brain activity by looking at the blood flow. EEG, these record the brain's electrical activity by scalp electrodes. So how is this covert consciousness detected? The first is the functional MRI mental task test. Asks the patient to imagine playing tennis or walking through their house. If the brain shows similar activity as a healthy volunteer, covert consciousness is present. EEG with command testing, patients hear commands while EEG monitors the brain activity. For example, wiggle your toes. The EEG detects brain tries even if there is no motor response that is detected. Other tools which are less commonly used are papillometry, tracking the pupil responses, eye tracking, following a moving dot. So, say for example, a young traumatic brain injury patient is showing no physical response for the last 6 months, but then we detect with functional MRI or the EEG that there is brain activity. So internally that patient is conscious, though outwardly that patient is unable to show any motor activity regarding it. In EEG based studies, patients with this dissociation had a 44% chance of regaining independence by 1 year, while only 14% of those could regain consciousness or independence without this activity. So the challenges are there in detection. The ICU environment has noisy alarms, frequent interruptions, language mismatches. There are patient factors like sedation, pain, hearing loss, aphasia, delirium. False negatives are common. Not detecting consciousness doesn't really mean that it's absent. Interpretation requires expertise, clear communication with family. So what are the practical ICU implications? EEG is the best fit for ICU, portable, repeatable, less costly. Functional MRI is more detailed, but to use it regularly in the ICU has a lot of problems because it has costs, there is logistic involved, and transportation has to be done. If covert consciousness is detected, avoid any premature decision about withdrawal of care. Consider rehabilitation strategies early, use it in clinical trials to guide treatment subgroups. Ethical and communication consideration. Explain results to the family carefully because results are not really black and white over here. So, for example, a patient having a positive functional MRI or EEG doesn't mean is going to be okay in few days. Similarly, if the patient doesn't have an activity, doesn't mean the patient is going to die or be comatose all life. Anything can happen. So explain accordingly, not black and white. Always provide pre and post test counseling. Use covert consciousness finding as a part of larger picture, not just in isolation. It's a tool in the larger scheme of the events. Prognosticate humility is key. Don't rush decision based on limited amounts of tools. This is very critical because we are dealing with the life of a patient. So the final take-home points are: not all unresponsive patients are truly unconscious. Covert consciousness can now be measured using EEG and functional MRI. 1 out of every 4 patients may still be mentally present. And early detection correlates with better outcomes. ICU teams should stay alert, maintain respectful bedside behavior, and push for integrating EEG-based assessment wherever possible. So to summarize how this particular thing is to be done, please make sure that and have a checklist for testing before you go for this kind of a testing. Make sure that the patient is able to hear, the patient is not deaf, the ear canals are not blocked. If unsure, then go for brainstem auditory evoked potential to confirm that hearing pathway is intact. Next is motor weakness. The patient can have spinal cord injuries, critical illness, polyneuropathy and myopathy, which can impact the motor response. So test for tactile stimulus. Confounders: watch for things that affect alertness like sedation, sepsis, metabolic derangements, and noise. Try to minimize this before you're going for a test. EEG signal quality: avoid artifacts, seizures, or periodic discharges that may distort the EEG interpretation. Neurobehavioral examine: ensure there is no physical response to verbal command. This rules out an overt consciousness. What happens during the EEG test? Play a recorded command like wiggle your toe. Then the machine learning checks for brain response despite no physical movement. So how do we interpret? We can interpret it in 2 ways. The first is the left side, where you do find a response. In this, the EEG picks up brain activity even though the patient has shown no outward movement. What it means that 44% of such patients achieve the Glasgow recovery scale of more than 4, that is functional independence, within more than a year. Recovery is faster in this patient and more likely than those without this response. It predicts good outcome and it is independent of the age, injury type, or initial neurological status. Other thing that is on the right side, you may find that there is no response, but be cautious. False negative is possible because of aphasia, because that is the patient is unable to understand your language, a patient is having language barrier, or there is inattention or sedation. So keep those things in mind before you are interpreting negative. Thank you for your patience.